Good morning. This is your Airway lecture part 2. Just very few number of slides this morning as we talk about components of the airway and look at things maybe in a little bit different perspective than you would look at them as an EMT. The follow-up for this lecture will be in the lab next Monday when we look at the equipment a little closer and apply why to use this specific type of equipment in different patient types. The most critical life-saving technique you can perform is establishing and maintaining a patent airway. Brain damage can occur after about 4 to 6 minutes without oxygen. After 10 minutes, the brain suffers irreversible damage to the point of death in some areas of the brain. So this is why the American Heart Association recommends that lay rescuers perform chest compressions without ventilations in order to circulate the roughly 20% of oxygenated blood that's already in the left ventricle. A patient who has a partially obstructed airway can still speak. If airway exchange is adequate, then you don't need to do anything. You only need to do something if the patient becomes cyanotic, and then air exchange is not adequate. And then if the patient becomes cyanotic or you hear stridor or whistling, and at that point you understand that this is not just a partial obstruction, you'll treat it like a full obstruction. Complete airway obstruction can cause hypoxemia, which is low oxygen concentration in the arteries. Hypoxemia leads to cardiac arrest as it progresses. The most common airway obstruction for an unconscious patient is their tongue. And I bet y'all probably didn't know that. But the most common airway obstruction for an unconscious patient is their tongue. Unconscious people can't protect their own airway. So being unconscious is not what causes the cardiac arrest, but it's the tongue obstructing the airway that is the true problem. Laryngospasms are often caused by aggressive intubation techniques in cases where there's no other reason for airway swelling. So what I'm talking about here is not a patient who has epiglottitis or trauma to the subglottic area. I'm talking about a patient who has laryngospasms because of an intubation. A lot of times if you're too aggressive with your blade, you're going to irritate that area and you're going to cause it to have muscle spasms. The recommendation for laryngospasm is a forceful jaw thrust or the use of muscle relaxants. That's the most common recommendation if your patient's experiencing laryngospasms. There have been several studies conducted about the usefulness of lidocaine in laryngospasms, and the lidocaine can either be applied topically or 2 milligrams per kilogram IV, but it's extremely short-acting. And the best way to handle that situation is steady pressure against the vocal cords with your ET tube. So if your patient's having laryngospasms, perform a forceful jaw thrust to try to relax those muscles, administer a muscle relaxant, or apply firm steady pressure with your ET tube to try to slide on through the vocal cords. Swelling of the glottis and subglottic opening can close off the airway. The recommendation for swelling is aggressive airway management up to and including surgical airway placement. Laryngeal fractures can be the result of trauma to the neck, and they can cause vocal cord collapse or laryngeal hemorrhage. Both of these things will compromise the patient's airway. You need to be alert to voice changes if their voice is hoarse, if they have pain on palpation, if there's stridor present, or an inability to speak. Have your airway equipment ready. Have it ready early when you suspect that this might occur, and be prepared to perform a cricothyrotomy. When the larynx or trachea is completely obstructed, the person can die of asphyxiation within minutes. Tracheal trauma is rarely an isolated injury. Most of the time, it's going to come with head injury or cervical trauma. The management of laryngeal and tracheal trauma is controversial at best when you read the literature that's published by the National Institute of Health. I did find in Chapter 40 in your Mosby text that there's even disagreement between medical directors. Some medical directors will recommend oral or nasal intubation to secure a patient's airway with this kind of trauma, while other ones recommend follow basic airway maneuvers and get them to a hospital for surgical intervention. What you're going to have to do is know your local protocol and use your best judgment in the field, and always err on the side of the patient while staying within your protocols. So here we go again with everybody's favorite word, pathophysiology. But we're going to talk about the pathophysiology of aspiration. Two things can cause aspiration: a decreased level of consciousness, a mechanical disturbance of the airway or GI tract. These two things can cause aspiration. The common element in both of these problems is a suppressed gag reflex. An example of a mechanical disturbance of the GI tract would be vomiting. Vomiting follows stimulation of the vomiting center in the medulla. This can occur even after head trauma. An example of a mechanical disturbance of the airway would be oral or dental surgery, an improper intubation, or a tracheostomy. Improper intubation, what I'm talking about there is, maybe you didn't inflate the cuff on your ET tube, or maybe you didn't check your equipment and the cuff had a hole in it. Improperly traced tracheostomy can sever vessels in the area and cause the patient to aspirate blood. The effects of pulmonary aspiration, it's generally accepted that severe pulmonary damage can occur when your pH of aspirated material is less than 2.5. So at 2.5 or less, this causes kind of like a burn to the pulmonic tissues. When the pH is 1.5 or less, the patient usually dies. And keep in mind, so at 2.5 or less, if your patient inhales stomach fluids, for example, who have a pH below 2.5, you're causing a burn injury. They're causing a burn injury in their lung tissue. The lungs are not designed to withstand those acids. The permeability of capillaries increases when the alveoli and bronchi are flooded with fluid. So the increased permeability can cause a fluid shift from the intravascular space into the lungs, which will potentiate, means it makes it worse, it will potentiate hypoxia and can cause hypovolemia enough to require fluid resuscitation. So that is the pathophysiology of aspiration. So we've got an inhaled fluid that is acidic, which is causing burns on the inside of the lung tissue. The body's response to that is an increase in permeability. So when the permeability changes, then there's a fluid shift from the intravascular space into the lungs. And that increases hypoxia and can cause hypovolemia enough to require fluid resuscitation. Now, before we can figure out what's abnormal, first we need to know kind of what normal is. And that's with anything that we evaluate. The normal respiratory rate for an adult is 12 to 24 times a minute. If there's a steady inhale-exhale pattern, then that's regular. Breathing should not require effort if the person is at rest. Using effort means there's a problem. Look for signs of one of the following: a ventilation-perfusion mismatch, upper or lower airway obstruction, impaired muscles or impaired nervous system. One of those things has got to be present. And remember, the brain can only survive just a few minutes without oxygen before there's irreversible damage. If you don't have a patent airway, then nothing else matters. Observe your patient. Look for outward signs of respiratory difficulty like cyanosis, use of intercostal muscles, tripod positioning, and then auscultate your lung sounds. So not only are we observing our patient, we're listening. Auscultate lung sounds. Snoring comes from the oronasopharyngeal area. If your patient has inspiratory stridor, that comes from the supraglottic area. Expiratory stridor will come from the lower trachea or bronchi. You have to understand what I'm talking about here. Inspiratory stridor means they have stridor on inhale. Expiratory stridor means they have stridor on the exhale. So we observe our patient, we auscultate our patient, and now we're going to palpate our patient. We have to touch them. Palpate the chest and look for paradoxical motion, signs of trauma, or other abnormalities. Percuss your patient. Percussion is helpful in determining the presence of air or blood in the chest cavity, even if you don't hear it in the lungs. You can have air or blood in the chest cavity that can put pressure on the lungs that can decrease the amount of tidal volume coming in. If your patient's intubated and you notice a difference in the chest wall compliance, then there's a problem. That means there's a factor that's keeping that lung from ventilating the way it should be. With pulsus paradoxus, you're going to need to know it. I'm sure it was on your EMT exams, and it will also be present on your National Registry Paramedic exam. However, it's not a practical thing for us to perform in the field, but you do need to know what pulsus paradoxus is because you will be seeing it in the clinical setting. Pulsus paradoxus is an exaggerated blood pressure change during breathing. During normal breathing, the systolic blood pressure will drop only slightly when you inhale. So imagine it, if you're taking a blood pressure on somebody, you have to time it just right so that you're listening to the systolic number as they inhale. And during that time, the systolic blood pressure will drop, only slightly. If the systolic blood pressure drops more than 10 millimeters of mercury during an inhale, then that is pulsus paradoxus. And again, it's difficult to assess in the field, but usually pulsus paradoxus comes hand in hand with a patient who has some type of pulmonary obstruction, a lot of times with COPD. History is an important part of your evaluation. So when you're talking to your patient, what's going on today? You ask them, what's going on today? What makes it better? What makes it worse? Have you had any past treatment for how you're acting now? How long has this been going on? How long ago was your last event? And the most important question you can ask a patient or their family who's in respiratory distress to the point of respiratory failure, you ask them, have they been intubated before for this problem? And have they been on a ventilator before for this problem? That's your telltale sign that you're going to need to be aggressive with your patient. So always ask, if patient can't answer you, ask the family members. Has this ever happened before? Did they have to be intubated? Were they on a ventilator? Those questions are super important to your assessment. And if you look on the right-hand side, These are renderings of breathing patterns. Yeah, I'm sure you've seen these images before in your EMT book. We're going to talk about just a few of them today. These are a representation of inadequate respirations versus a normal rendering of normal respiration. Agonal respirations are gasping, followed by apnea. Ataxia is a cluster of irregular breathing that normally indicates some type of pressure on the medulla in the brain. It's going to lead to apnea. Biot's respirations are similar to ataxic respirations, but they're more commonly associated with a head trauma, whereas ataxic respirations can be indicative of a brain lesion. Biot's is also closely related to Cheyne-Stokes, which sometimes indicates a critical brain dysfunction. Cheyne-Stokes is a regular breathing pattern with crescendo, decrescendo sequencing, and it can be experienced by some people during normal sleep. Kussmaul respirations are abnormally deep and very rapid. Most patients with Kussmaul breathing patterns are going to be in metabolic acidosis or have DKA, diabetic ketoacidosis. Inadequate respirations can be broken down into two components: an inadequate ventilation and inadequate oxygenation. Inadequate ventilation basically means that there's a problem with the mechanics of the breathing. There's a problem keeping the air from coming in and out. Inadequate oxygenation means that there's a problem with gas exchange, like a pulmonary emboli or pneumonia, something that's keeping the gases from being exchanged at the alveolar level. So remember that. If your patient has inadequate respirations, it's one of two problems. Either it's a mechanical problem or it's an oxygenation problem. Both of these things we can work on trying to fix. So here is your review of oxygen cylinders, regulators, and flow meters, and forms, and tank factors, which, by the way, you need to write these down on a tiny little piece of paper. The tank factors, write those down for the various sizes of oxygen tanks. Tape them to the back of your cell phone. Get them tattooed on your arm. Whatever you're going to need to do to remember those, because when you're trying to learn how many minutes you have left on a tank and is it going to help you transport your patient to Lexington, then that's a very important piece of information to have. Oxygen tanks come in size M, E, Jumbo D, and D. Most of your tanks are considered empty at 200 psi. Now that's a safe pressure for a tank. Some services may say, no, we're calling it empty at 700 because we can't make a run on 700 psi, which is fine. But, you know, the national accepted level is 200 psi. To find out how long your tank will last during oxygen administration, first you need to look at the psi of the tank. Subtract the pounds of pressure per square inch in the tank, subtract the 200 psi from that. And let me skip ahead just a second here. There we go. Here's our formula. Subtract 200 psi from the pounds of pressure in your tank. Then you're going to multiply the tank's factor by the remaining psi. The factor is listed in your Mosby textbook. It's in one of your little boxes listed in this section of assigned reading. So you look at the psi of the tank, subtract 200, then multiply that by the factor And that gives you the amount of gas in the tank. Divide the amount of gas in the tank by the oxygen flow rate, and that's how many minutes your tank will last. Oxygen factors don't change. And on page 418 of the Mosby text, that's where you're going to find your factors for the most common tanks. And like I said, you're going to need to commit those to memory. And so I've given you here an example. If your tank has 200 psi, your oxygen delivery is going to be at 6 liters a minute, and you're using a D-size cylinder, and the factor for cylinder D is 0.16. So 2,000 minus 200 is 1,800. That's our volume. Multiply our volume times our factor, which gives us 288. 288 divided by our 6 liters a minute means our D tank will last 48 minutes at 6 liters. Now we're going back up, talk about oxygen delivery devices. So nasal cannulas are for patients who benefit from low oxygen delivery. Cannulas running at 1 to 6 liters can deliver 24 to 44% oxygen. So 24 to 44% oxygen, and that's because it's not a mask and it's mixing with ambient air. Your simple face mask has no oxygen reservoir. It has uncovered vents on the side that allows for air mixing with ambient air, and it allows for the escape of exhaled air. A simple mask runs at 6 to 10 liters and it can deliver 35 to 60% oxygen because it's mixing with ambient air. So it's slightly better than a nasal cannula. Partial rebreathers are not to be confused with non-rebreathers. Now remember that partial rebreathers are not to be confused with non-rebreathers. There's a vital difference on the inside. They have an oxygen reservoir bag just like a non-rebreather, and they have vents on the mask covered by a one-way disc just like a non-rebreather, but they're different. Partial rebreathers deliver 35 to 60% oxygen at 6 to 10 liters a minute, and anything above 10 liters, it's not going to work any better. So there's difference number one. Partial rebreathers, 6 to 10 liters a minute. The second thing is, with a non-rebreather, there's a flutter valve on the inside which keeps the exhaled air from entering the reservoir bag, thus the name non-rebreather. So on the inside of the partial rebreather, there's not a flutter valve. So the patient's exhaled air can go into the reservoir bag. So they're partially rebreathing their exhaled air. In a non-rebreather, the difference is that little disc on the inside, the flutter valve that keeps the patient's exhaled air from going in the reservoir bag. The exhaled air has no choice except to go out the vents on the side of the mask. So that's called a non-rebreather. So non-rebreathers can run from 10 to 15 liters a minute and deliver oxygen concentrations from 80 to 95%. I know we call it 100% O2, but technically it's up to 95%. A Venturi mask uses jet mixing of atmospheric gas and oxygen to deliver a precise oxygen concentration. Venturi mask can deliver from 25 to 50% oxygen, and there are different color-coded adapters to help you get this process going. These will work best for patients who rely on hypoxic drive. And here we've talked, this is our tank formula again, and which brings us to the end. And this is a quote from Trevor Richardson. He writes dystopian novels. So if you're interested in those things, you might want to look up his work. He's pretty interesting. Here's his quote. "We were like two atoms in one molecule, hydrogen and oxygen, both explosive alone, but the source of everything when we came together." Okay, so what I want you to do now, is reread this section in your Airway book. I'm going to post my notes on the Blackboard shell. That way you'll have a copy of them. But I need you to read this section and understand it. Also, I want to point out now, I do remember, Chris Mason, what it was that you were supposed to look up and what Clay was supposed to look up. And so we're going to talk about those things on Monday. I'll email you what it was you were supposed to look at. Okay, you all have a great day.